Hello, St. Mary's Medical Center nurses, and welcome to your Reverse the Cycle nurse training. Today, we're going to be talking about the Reverse the Cycle program in the emergency room at St. Mary's and your role as a nurse in implementing this program. The objectives for our training today are for you to understand the evidence-based SBIRT model, all components of the Reverse the Cycle program, how it's implemented at St. Mary's in the emergency room, and what your role is as a nurse in completing screenings and conducting COWS assessments. So we're currently in the midst of a national public health crisis related to substance use. In 2019, there were about 21.6 million Americans who needed substance use treatment. That's 1 in every 15 people. But only 2.6 million of those Americans, just 12%, actually received the treatment that they needed. That's a huge disparity. And in 2019, 35.8 million Americans 12 and older were current, meaning within the past month, illicit drug users. And drug overdose is the #1 cause of injury-related deaths in the United States. Every year, about 20 million people go to the emergency room for illness or injury, and 15 to 20% of those people would actually screen positive for a substance use disorder if they were screened. For trauma-related visits, we see that increase to between 25 and 50%. You can see from this graph that opioid-related emergency room visits have been rising since 2010. Looking at opioid-related inpatient stays, we see that West Virginia had a rate of more than 441.5 opioid-related inpatient stays per 100,000 population, and that's one of the highest in the country. 2020 really exacerbated the opioid epidemic and the substance use epidemic because of COVID-19. We saw drug overdose deaths increase 30% nationally. So in 2020, there were 92,183 drug overdose deaths, and 69,710 were attributed to opioids. So that's 76%. And West Virginia is the highest among the states for opioid overdose deaths. While national overdose deaths increased by 30%, West Virginia's drug overdose deaths went up by 49%. So we really saw things get a lot worse during the year of 2020. Between 1999 and 2018, we see opioid overdose deaths really increasing. It starts to steadily increase in the early 2000s here. And then as prescription opioids become more and more available, we see prescription opioid overdose deaths really increasing and spiking here in 2011. Prescription opioid overdose deaths start to decrease in 2012, 2013, but at that same time, we see the introduction of fentanyl and carfentanil. And so that's this yellow line here. When we see prescription opioid overdose deaths start to decrease, we see synthetic opioid overdose deaths like carfentanil, fentanyl increase. They really start to shoot up right here in 2017. At the very bottom, you see drug overdose deaths related to heroin. So that's the lowest of all three with 195. Looking specifically at Cabell County, from 2018 and 2020, Cabell County witnessed 448 fatal overdoses per 100,000 population, and 366 of those were related to opioids. Cabell County has the highest rate of drug overdose deaths in the state of West Virginia. The majority of those overdose deaths are occurring for males between the ages of 20 and 59, and mostly really those 30 to 59 area here. So what do we do to address this epidemic? Well, Mosaic Groups partnered with St. Mary's Medical Center to implement this Reverse the Cycle program that I've been speaking about that aims to address substance use response in the hospital. So This program includes 3 components. There's universal screening and peer intervention, which you'll sometimes hear us refer to as SBIRT. And then there's the Overdose Survivors Outreach Program, or OSOP. And the third component is MAT initiation in the ED. St. Mary's Medical Center has peer recovery coaches who've been integrated into the emergency department to deliver brief interventions and referrals to treatment for people who might be using or drinking at risky levels. So the protocol at St. Mary's Medical Center is that all patients 18 years of age and older are going to be screened by a nurse during their primary nursing assessment. If they screen positive, then the medical team is going to put in the EMR that the patient is positive, and that's automatically going to notify the peer recovery coach that there is a patient for them to see. The peer is going to go into that patient chart, review the patient's scores, and discuss patient information with the nurse, and of course, decide upon a time to go into the patient's room to provide a brief intervention. So the nurse will let the peer know when it's appropriate to go in and see that patient. And when the peer goes in the room, they're going to develop a plan with the patient and schedule any necessary appointments, complete any referrals to treatment. So as I mentioned, the protocol at St. Mary's is that all ED patients 18 years and older are going to be screened by a nurse during nursing assessment. To access that screening, you go into primary assessment, screenings, and you select adult SBIRT screening. The screening tools that we're using, which are located in Cerner, are the Audit C and 2 drug questions for illicit substance use and prescription drug misuse. The Audit C stands for Alcohol Use Disorder Identification Test Concise and consists of 3 questions. It is a validated screening tool to screen for risky alcohol use. A score of 7 or more on the Audit C indicates that your patient is drinking at risky levels and would benefit from a peer recovery coach consult. So if you have a patient who scores 7 or more on that Audit C, or you have a patient who says yes to either of the drug questions, then you want to select SBIRT positive, select PRC consult, and this will notify the peer. There are exclusion criteria, which is for those times when you're not able to screen a patient. Some of those instances include a patient being too intoxicated or having overdosed. A patient may be unable to participate in the screening because they're critically ill or maybe nonverbal. And you have those patients who are going to refuse to answer the questions. And we also don't want to screen patients who are in police custody. This last exclusion criteria is called provider request. What that means is you might have a patient who answers the questions in such a way that they screen negative, right? But you as a provider see something or, have a suspicion that this person might be drinking or using at risky levels, and you'd like for a peer recovery coach to go in and see that patient. So something to know about exclusion criteria is that when you select intoxication, suspected overdose, opioid overdose, or provider request, that will still count as a positive SBIRT screening. So even though you will not ask those 3 alcohol questions or the 2 drug questions, maybe for some of these folks, they will still get a positive screening because of your selection, exclusion criteria selection. This is what the SBIRT screening looks like in your EMR. So you can see we have the exclusion criteria here up at the top. And of course, anyone under the age of 18 is not going to be screened. So that is an additional screening criteria. And after that, you see the 3 alcohol-related questions. So how often do you have a drink containing alcohol? How many standard drinks of alcohol do you have on a typical day? And how often do you have 6 or more drinks on one occasion? And it's really important that you ask these questions verbatim. There's a difference between asking, do you drink, versus asking, how often do you drink, have a drink containing alcohol? We've found that it really benefits having asking these questions verbatim. We get much more accurate screenings when we do that. So that's important. Based off of the response, you're going to get a point value right here. So all of these responses have different point values. And based off of those responses, they're going to total all the values together, and you're going to get their audit C score right here in this box. If the patient scores 7 or more on the audit C, again, that means that they have a positive screening. You then have your 2 drug use questions here. So in the last 12 months, did you use any recreational drugs? Yes, no. In the last 12 months, did you misuse any prescription medications? And then if the patient says that they have used any recreational drugs or misused any prescription medications, you want to indicate what substances it is that they have used or are using. And then at the bottom, if you have a positive screening, you want to make sure to select SBIRT positive, request PRC consult. Otherwise, the peer will not be notified and it won't really be tracked as well. So you want to make sure to select this when you have a yes to the drug question or 7 or more on the audit C. So if the patient is positive and you have selected yes to the PRC consult, the peer is going to be triggered on the tracker board. So a green star is going to populate on their CMS column. And then the peer recovery coach is going to go check in with you to talk about the patient, understand when the best time is for them to go into the patient room to provide that brief intervention. Peer recovery coaches are individuals in long-term recovery from substance use disorder, and they're trained in motivational interviewing, and they use their lived experience to connect to patients and really help those patients who are in active addiction. You have really great peer recovery coaches in the emergency room there at St. Mary's, 3 full-time peers in the ED, and then you have 1 peer who actually works out of the community doing overdose survivor outreach. These peers have been employed by Marshall University and they are housed in the ED. So these peers give brief interventions and they make referrals to treatment when appropriate for patients who screen positive in the ED for risky alcohol or substance use. Another component of the reverse the cycle model is the overdose survivors outreach program, which we're going to talk about soon. The overdose survivors outreach program provides intensive outreach and follow-up in the community for patients who have come to the ED as a result of an overdose. So the next component of the Reverse the Cycle program is MAT initiation in the ED and what we call fast track referrals. Patients in the ED who begin or who are already experiencing withdrawal can receive an 8.2 milligram dose of buprenorphine naloxone or Suboxone and begin to feel better. This allows them to participate more actively in their treatment and to better understand their discharge instructions. And patients who get this buprenorphine in the ED are much less likely to leave AMA. We know that when patients start to feel sick, they want to leave, they're less likely to follow through with their treatment, and it's harder to engage them. When they feel better, they're less likely to use illicit substances before going to treatment. And patients who are not using substances are more likely to engage in treatment within 24 hours. And patients who are engaged in recovery are more likely to comply with follow-up healthcare visits and thus less likely to visit the ED. So to initiate MAT at St. Mary's, the peer is going to confirm that a patient is motivated for treatment and willing to go to treatment the next day, and that their primary substance of choice is opiates. When this happens, they are going to refer that patient to the provider for MAT initiations. They're going to go to the provider and let them know they have a patient who's eligible. The provider is then going to evaluate that patient to see if they're clinically appropriate for the buprenorphine naloxone in the ED. To be clinically appropriate, the patient has to meet the DSM-5 criteria for opioid use disorder, and the provider is going to check and see if the patient has any contraindications to the use of buprenorphine. Some cautionary criteria are prescribed or illicit benzodiazepine use, pregnancy, and clinical evidence of liver disease. Some exclusionary criteria, cases in which you would not give buprenorphine naloxone, is when the patient's already appropriately taking prescribed long-acting opioids, or when the patient has acute psychiatric illness or an allergy to buprenorphine or naloxone. So then if the patient is clinically appropriate according to the provider's evaluation, the provider is going to ask the nurse to complete the Clinical Opiate Withdrawal Scale with the patient. The nurse is going to go complete the COWS, what we call the Clinical Opiate Withdrawal Scale. And if the patient scores 8 or more on the COWS, the nurse is going to notify the provider verbally of the COWS score and let the provider know that the patient needs the 2 milligram dose of buprenorphine naloxone. So pregnant patients are going to be ordered the buprenorphine tablet, the Subutex. So ED nurses are then going to administer the medication and observe that it's taken in the manner in which the patient has been educated by the nurse in the ED. And we'll go over that in a couple of slides here. So what is the COWS? The COWS is a method of recording scores for various symptoms of opiate withdrawal. It's used to determine the level of withdrawal a patient's experiencing, and it's used in healthcare settings for patients who've received opiates for the treatment of pain and who are showing adverse signs of opiate withdrawal as a subsequent result. This advises the clinical team of the need for induction of buprenorphine. So the sum of those numbers determines the level of withdrawal a person is in, and it helps them to determine the next course of action. Nursing is going to be notified whenever they need to complete the COWS. In order to get to the COWS, you'll go into Sorian Clinicals, navigate to charting, and click on assessments. The COWS will be on the list to the right-hand side, listed as Clinical Opiate Withdrawal Scale. We have a screenshot of that here. So you'll go through and you'll answer all these questions and it will automatically score for you. So how does buprenorphine work? Well, buprenorphine is a partial agonist. Methadone, you see, is a full agonist, and naloxone is an antagonist. So buprenorphine's right here in the middle, and it has a ceiling effect for opioid effects. It has a high affinity for the opioid receptor and slow dissociation from the opioid receptor. It's formulated with naloxone, which blocks opiates, the opiate effect if it's injected. And naloxone is degraded slowly if taken orally. Here we have an image that depicts the difference between buprenorphine and other opioids. So buprenorphine are these little yellow circles, and opioid is this big circle up here, this big green circle. So you have this empty receptor here, and as a result, there's withdrawal pain. If you put an opioid in that receptor, there's a really great fit. It's a perfect fit, which means the patient's going to have maximum opioid effect. They're going to feel euphoric, and that's what would happen if you gave them an opioid. There's no withdrawal pain, but they do have that euphoria. On the other hand, if you give the patient buprenorphine, you see that there's an imperfect fit, which means that there's a limited opioid effect. So they don't have withdrawal pain, right? But they are not getting that euphoria. So that's what we mean when we say ceiling effect. If you don't get as high, you don't get high from buprenorphine. It blocks the opioid receptor as it dissipates, blocks opioids as it dissipates. This is the patient education you're going to give when you are in doing buprenorphine induction. So the sublingual tablet or film is held under the tongue until dissolved. You start with a moist mouth. You avoid any acidic drinks like coffee or fruit juice, and you don't want the patient to smoke immediately before or after. You don't want them to talk during administration. We really want them to keep that tablet or film under their tongue until it completely dissolves. It's important that we prevent against precipitated withdrawal. This is an extremely painful experience for patients. Precipitated withdrawal is more likely to occur when a patient has a really high physical dependence and when there's been a short time since their last opioid use and when that initial dose of buprenorphine is too high. That's why we only dose 8 milligrams, which is relatively low. In order to prevent, the way that you prevent precipitated withdrawal is by administering the first buprenorphine Suboxone naloxone dose when objective signs of withdrawal are present. This is the MAT order set that you have in your EMR that goes through all of the steps that I just described, the consult with the peer recovery coach to confirm patient motivation, the provider going in and checking to see if the patient's clinically appropriate, do they meet any cautionary exclusionary criteria, and we have here the nurse completes the COWS and administers the medication. While this is all going on, the peer recovery coach is working to connect that patient with a treatment appointment within 24 hours. So we have developed a network of fast track providers who have agreed to accept these patients who have been induced in the ED within 24 hours of their discharge. We really don't want that 8 milligrams to wear off. We want to make sure that patients get their next dose within 24 hours. So we have special referral processes for these various treatment programs that help peer recovery coaches to get patients into these programs quickly. So the peer is not going to recommend a patient to be dosed unless they've confirmed that the patient really is ready for treatment and there is an available appointment the following day. Now, the next component of the program is the Overdose Survivors Outreach Program. So following an opioid overdose in the emergency room, a peer recovery coach is going to meet with the patient and provide overdose prevention education as quickly as possible and discuss risks of use after naloxone administration, and will introduce the OSAP program to this patient. It's important that they work quickly because we know that these patients are likely to bolt, and we want to make sure that they have education that's going to help them prevent a subsequent overdose. The OSAP peer is then going to connect with that patient within 24 hours. The OSAP peer is going to follow up with them for up to 90 days, up to 3 times per week. They help to connect these patients with naloxone and recovery support services like employment resources, transportation resources, childcare, anything really that's going to support this person's recovery. They also help the patient connect to substance use treatment programs if and when they're ready, and they coordinate care and services, anything possible to prevent subsequent overdoses. So in summary, the reverse the cycle model includes SBIRT, or Universal Screening and Peer Intervention, MAT in the ED, and OSAP. So step 1 is that you screen all patients 18 years of age and older in the ED during your nursing assessment. And patients who screen positive, you're going to select refer to a peer recovery coach. The peer is then going to provide a brief intervention and develop a plan with the patient, which could include MAT initiation in the ED. And the peer is going to document that brief intervention and plan for a follow-up with that patient. The patients who have overdosed are going to be referred to OSAP, and the OSAP coach will provide the patient with resources and referrals as necessary. For any ED patients, the peer recovery coach will also be involved in those referrals to treatment. And follow-up calls are going to be scheduled for patients. So thanks so much for taking time to view this training today. Really appreciate your work in the emergency room and look forward to hearing how this goes for you. Please feel free to reach out at any time. This contact information here is for the president of Mosaic Group, Marla Oros. Her email is moros@groupmosaic.com, 410-852-4263. And then you have Dr. Tiffany Latham here, who's our senior behavioral health consultant, and her email is tlatham@groupmosaic.com. And 443-613-0351 is her cell phone number. She's your primary consultant. If you have any questions, please don't hesitate to reach out.